Good evening, all. I am going to present a case hepatic transplant. How could you save by percutaneous intervention and stenting? After this session of coronary intervention, I want to present a rather interesting case. Basically, with the history, a 51-year-old male who underwent donor liver transplant on 12th May this year, just 2.5 months back. On 12th day, patient present with fever and pain. The patient present with fever, pain, abdomen on 12th date of liver transplant. So, and the patient was investigated, and it is found to be patient having high TLC, and the hemoglobin is low, and the CT scan showing some collection, and the patient was managed conservatively for 3 to 4 days with antibiotics, blood transfusion. But this hemoglobin is falling, hemoglobin was falling down, and patient was not improved. So surgeon decided to do explode laparotomy on 28 May, means after 16 days. They have done they repaired the hepatic artery, and patient was on ventilator, all the things. On the routine investigation, they will do Doppler after 6 to 8 hours. Okay. While doing Doppler ultrasound, again there is hepatic, this artery showing no flow. And they are suspecting some hepatic artery occlusion during ultrasound. And it was the surgery was done and around 4 to 5 o'clock, and this ultrasound done on 12 o'clock in midnight. So patient was ventilator, and they tried to stabilize it, but instead of all these things, patient was deteriorating. It become hemodynamically unstable. So this options were this plan where this you can do angiography, this conventional angiography, no need to point to CT angiography, or possible hepatic artery stenting and catheter directed thrombolysis plan. So if everything fails, then obviously re-exploration again. Hard time percentage go re-exploration hepatic repair. So this case in the next morning, we decided to do angiography. The right femoral artery selected, and JR this because this special arteries were not, special catheters were not there. So we choose a JR 6' catheter and the regular PTCA guide wire microcatheter. And this right femoral access was assessed, and the celiac artery access with the JR. And this is celiac angiography. You see, this is the celiac artery, and this is splenic artery. This is the common hepatic artery. The total occluded. See, it is a thrombosis is there. There is no flow. This is liver side. There is no flow. You see this? This is the splenic artery, and this is celiac trunk. This common hepatic artery. This is the diagram, schematic diagram. This is this splenic artery. This is left gastric artery. This common hepatic artery. It is blocked from here. So totally hepatic artery circulation was blocked. So what to do? Patient was hemodynamically unstable. So you plan for this stenting and catheter direct thrombolysis. So the JR catheter we hooked passed to PTCA wire with a microcatheter. It was not giving proper support. So use a Godzilla 6' guiding extension catheter with a microcatheter supporter. You could cross the lesion. But you see, this is the some hepatic flow is there in left artery, but you will see we're not sure where this patient is. Artery is in lumen. So after confirmation, we dilated with 2.10 balloon and 2.12 balloon. See, what is this? The balloon is dilated here, and this is the flow. Because the patient is hemodynamically compromised, and need to go for this stenting. Ideally, the cover stent is ideal because this is to see this the clip. This is the second day of post operation. The surgery afraid of this again the surgery, this suture leak. So you have to need to cover this and followed by catheter direct thrombolysis. Since proper size of cover stent was not there, so use this coronary stent. It is Onyx Jotanibus 2.5 to 22 mm place along this suture, and it was dilated to 10 atmosphere pressure. You see there is a flow, and you see there is a good flow, although there is some heaviness here. And this is the this hepatic artery, proper hepatic artery. This is the left and this is right hepatic artery. To hold the liver is parenchyma is vascularized, and it looks good. So to see this after injection, this looks total liver is well vascularized, and although there is some residual problem there, and this switch point was saved, and there is some hedginess. So you decided to do again with the catheter directed thrombolysis also. So this is the mic, this wire, and this the microcatheter tip was there just proximal to this stent, and this is still given injection to confirm this. You see this microcatheter in there, and we also decided to do catheter directed thrombolysis because it is this normally hepatic artery thrombosis. You could say we could manage with this catheter directed thrombolysis, because in this case, especially is the patient underwent liver transplantation just 16 days back and explored laparotomy 1 day back, and surgeon was just very much embraced, just apparent that again it will be, if you do direct catheter thrombolysis without the stent, although this cover stent will be better, but still it is safe. And we given this multiplex injection, recognize injection also given 1 milligram per hour infusion for 40 hours. And obviously, we'll given dual antibiotic to given ecosmic propita. Other supportive measures like blood transfusion, antibiotics were given, and the patient was observed, and the gradual parameters improved. And after 48 hours, patient was hematology stable. Doppler ultrasound during the course shows normal hepatic flow, and patient exploded after 48 hours. So take-home message is, although it is usually are not the coronary stops and the cardiology not stops, the hepatic artery thrombosis is the most serious vascular complication. It ranges for 2 to 9%, and it requires urgent revascularization. These options, other options of hepatic thrombosis are reconstruction, surgical thrombectomy, radiological guided thrombolysis. Best is retransplantation. But retransplantation is always extreme option because the availability of donor, all the things. But prompt revascular in this case, although you did radiologically, you decrease the need for replantation in this cases. In this case, so at the end of the day, the surgeon is relaxed, and patient is also improved. And since this procedure done 2 months back, I think, and let's see the patient whether the patient is needs for further surgical exploration or not. The patient is doing better, and these are some procedures, non-coronary procedure also. The patient can be saved also. Okay, thank you.
Very interesting. So, what are the other causes of acute hepatic artery thrombosis which complicate liver transplants?
So basically, the hepatic artery thrombosis occurs due to infection, due to mismatch, and due to also infection like cytomegalovirus infection, and if there is a donor and recipient mismatch. And in this case, what I think also, because they have done re-exploration after 20 days, after 12 days, immediately after re-exploration, there is a thrombosis. Maybe due to this future problem, I think that in this case, that maybe this future stenosis, while also balloon dilating, it looks that there is some resistance. Yes, sir. In this case, I think it is due to this hepatic artery stenosis that is leading to this complication thrombosis.
Yeah. Okay. I think well done. It's quite an unusual thing, and I mean, you saved the day probably for both for the donor and the recipient. Any other questions?